Hello and welcome everyone. As we are all aware, VAP is a major complication in critically ill, intubated patients, causing high mortality, extended ICU stays, and increased costs. Thus, preventing VAP is crucial for patient safety and the cost-effectiveness of healthcare. Today we will discuss the non-pharmacological measures to prevent VAP, surveillance and infection control, implement a system for consistent VAP definitions, infection monitoring, and staff feedback. Lack of a clear VAP definition across studies affects outcome assessments. Essential preventive practices: shorten ventilation time, minimize the duration of invasive ventilation to lower VAP risk. Hand hygiene, essential for reducing VAP rates, mandatory for all staff. Head elevation, elevate the patient's head to a 45 degrees semi-recumbent position to reduce aspiration and VAP risk. Prone positioning, helps reduce VAP, especially beneficial in patients with severe respiratory distress, like ARDS. Specialized endotracheal tubes, subglottic secretion drainage. These tubes drain secretions above the cuff, lowering VAP risk. Other modifications: tapered cuffs, polyurethane cuffs, and silver-coated tubes show limited or negative effects on VAP prevention. VAP prevention bundles, combining multiple preventive measures, like hand hygiene, head elevation, subglottic drainage, can reduce mortality. Example of a VAP bundle includes daily assessment for ventilation needs, regular head of bed elevation, subglottic secretion drainage in prolonged ventilation. Interventions with limited evidence or increased risk. Closed suctioning systems, while they might reduce VAP, their overall impact is unclear, and high bias risk exists due to study design limitations. Silver-coated tubes and tracheal saline installation. Though these reduce VAP, they may increase mortality, possibly due to interference with pathogen detection. Lateral Trendelenburg position. Slight reduction in VAP but associated with side effects like oxygen desaturation. What are the barriers to implementation? Challenges include limited staff and resources. Tailored VAP prevention plans should consider local conditions and available resources. Practical strategies include team training, electronic reminders, checklists, and regular feedback on VAP rates. Future research and recommendations. More high-quality trials are needed to verify the effectiveness of VAP prevention strategies. Suggested areas for study: consistent VAP definitions, less biased methodologies, and the role of early mobilization and nutrition. Aim to improve post-ICU quality of life and reduce mortality. To wrap up, remember that ventilator-associated pneumonia, or VAP, is a critical challenge in ICU care. Preventing it requires a staged approach, moving from basic to advanced practices. 1. Start with the essentials. Strict criteria for ventilation, hand hygiene, and patient positioning lay the foundation. Though some measures like physiotherapy and prone positioning have mixed evidence, they can still play a role. 2. Improve by building systems. Develop a VAP prevention bundle adapted to your unit, with a strong surveillance system and infection control team. Add tools like checklists, team training, and consistent feedback to elevate these practices. 3. Aim for excellence. At the highest level, adopt measures like endotracheal tubes with subglottic drainage, proven to prevent VAP. Become a VAP prevention hero by mastering these techniques and sharing your knowledge with others. Lastly, every step counts. Even small actions like elevating the head of the bed or reinforcing hand hygiene can make a huge difference in patient outcomes. By continually building and refining our approach, we can make ICU care safer, reduce complications, and ultimately improve the quality of life for our patients. Thank you for watching, and let's keep raising the bar in VAP prevention.